I'll talk about Zika here, and I've been involved with Zika since the beginning of actually before we know that Zika. In late 2014, I received a phone call from a friend. He's a medical doctor in Takeda. So he called me and said, look, Maurício, we have our cohort here in North Brazil. We are studying it's a cohort set up for a dengue study, for a dengue vaccine trial, but we are having some dengue-like disease that's not dengue. And I said, what? What is dengue that's not dengue? Now, we have some cases here. This does not make sense. Can you help us? He said, for sure, send me the samples. But since this is a Takeda study, I work with the Butantan NIH vaccine, so there was a conflict. They decided not to send the samples to me. To be honest, I will never think about Zika at that point. So I forgot about this, and a couple of months later, this is a Brazilian newspaper, a mysterious disease strikes Northeast Brazil. At this time, we're talking about 8,000 cases of unknown disease. And this is the first evidence that our public health system failed. How can I have 8,000 cases of disease and does not identify the disease? Why? Well, anyway, so this disease was spread in Northeast, and then we have our first report of Zika in Brazil. This was published by Claudia Nunes. He was the senior author, despite this not the last author. But she was not the first one. Dr. Gubio from Universidade Federal da Bahia was the first one to identify Zika. And at that point, we say, fine, we just have another flavivirus here. Zika, it's a very dengue-related virus, very close to dengue. How Zika got in Brazil was not well understood at the time. We know that Zika was, how I get this? Oh, yeah, got it. So Zika was isolated in Africa. We knew that there was several outbreaks going on in the South Pacific, and then this showed up in Brazil. But to be honest, all of us virologists in Brazil say, okay, this really doesn't matter. That's not a major problem. What is Zika? Zika is a flavivirus that's closely related to dengue. Really, really close. Probably is the closest one. It's a virus that has Aedes mosquitoes as a vector, as you can see here. Dengue, Zika, and yellow fever are really closely related. We have all these viruses in Brazil at this point. So nobody was paying attention to Zika. We are really worried about chikungunya that also was introduced in South America at the same time. So last October last year, the Pan American Health Organization convened a small meeting on the experts in Buenos Aires. We were there. It was a meeting like this, a room like this, only 25, 30 people from Canada to Chile. We are worried about the chikungunya, dengue, and Zika. And Zika was like one small session in a 3-day meeting. Nobody was paying attention. At the end of the first day, someone sitting in the back of the room said, what about the microcephaly cases in Northeast Brazil? Everybody said, what? We never heard about anything like that. And I'm talking about a Pan American Health Organization expert meeting. Everybody looked at the face of the guy and said, are you out of your mind? This does not exist. Has never been described anything in like this for a flavivirus. And he asked 5 minutes, show some very preliminary epidemiological data suggesting that there was really a link between Zika virus infection and the genesis of microcephaly. So all hell breaks loose. We know what happened since then. This was late October last year. In November, the World Health Organization make the first report. The Brazilian Ministry of Health starts to put the notes in December, and then everybody becomes a virologist. That's a joke because there is a paper says that Zika was the causative agent of the biggest outbreak of virologists in history. So everybody knows about Zika now, but I would like to focus this talk in 3 topics, okay? First, the burden of Zika and, of course, dengue, because we need to know the real numbers of dengue and Zika, especially because we are talking about public health interventions. We have dengue-approved vaccines. We have several other dengue vaccines on trial. And we also have some Zika vaccines in phase 1 trials. So the bottom line is that if you want to license, not only license a vaccine, but use in public health, we have to do a cost analysis, cost efficacy analysis. And in order to get this, we have to know the real burden of the disease. The second data that I want to show you guys is a pregnant woman cohort. We set up a cohort from analyze this woman in a dengue endemic yellow fever vaccinated area. That's my city. And the last one, small conversation that I want to talk to you, is if dengue IgG can mediate antibody-dependent enhancement in Zika infection. This is one topic that lead to a lot of discussion. So what about the burden of Zika and dengue? This is official, this is why in Portuguese, but it's pretty much the same table that our colleague put in the first talk. By now in Brazil, in most Latin American cases, and how in Latin American countries, and it is official by World Health Organization that the diagnosis of dengue, Zika, and tick in an endemic area should be done by clinical epidemiological criteria. What does this mean? No test will be run in everybody. So that the doctor will look to this wonderful table. Okay, this guy has more fever, or his Zika has no fever. So Zika does not cause a thrombocytopenia. So this guy has Zika. Oh no, you guy has dengue. And so this is how we have all the statistics in Latin America. And so just to know, this is official from Brazil, we have 91,000 cases of Zika by, this was March or April. This is just a number to show. Can we trust this number? That is what we have, 91,000 cases of Zika. These are considered confirmed Zika cases. Well, let's check. So I went to my hospital and got 100 patients that have dengue. They were officially recorded as dengue in our public health system and checked them. Well, 45% of them were dengue, but some were Zika. And when we look at these patients, they have thrombocytopenia. This is not expected for Zika. They have NS1 positive for dengue. And none of them had conjunctivitis that everybody say that's a hallmark for Zika, and everybody have fever. So that table of clinical epidemiological criteria is giving us wrong numbers. But you can tell me, okay, you have a bias because you're talking about dengue patients. So let's do the other way around. So we went to our hospital, or not our hospital, this is what the public health setting in the system, and collected samples from patients that were recorded as Zika. They are all in our statistics as Zika patients. So we tested 454 patients. Only 87 had Zika, only 20%. 11% had dengue, and 1 has chikungunya. So the bottom line is the worst. More than half of them, they don't have neither Zika, dengue, or chikungunya. What these guys have? Well, this year, specifically this year, we had a flu outbreak out of the season. So I'm assuming a lot of these patients had flu. But the bottom line is that we don't know the real burden of Zika, tick, and dengue in Brazil. So this clinical epidemiological criteria that's proposed by the PAHO and the Brazilian Ministry of Health is not good enough when we have 3 arbovirus circulating at the same time. Maybe more than 3. We also have St. Louis encephalitis, like you guys have in the US, and also we have West Nile virus. So What does this mean? This means that we don't know the denominator for most indicators that we want basic epidemiological data for Zika. So if you don't have this basic epidemiological data, how are we going to calculate anything related to the public health system in terms of cost efficacy analysis? So in order to overcome this, we're going to need to carry out very expensive epidemiological trials. In order to have this, we're going to have very good serology, and we don't have. So I would like to talk a little bit about the spectrum of the disease. We don't know the spectrum of disease. Zika is showing up now in new presentations. We know in the past that Zika was a very mild dengue-like disease, but to be honest, we only described a few hundred cases before. Now we're talking about millions of people infected in Brazil. We have millions of cases, so the whole spectrum of the disease is showing up right now. We never heard about that. What happened in atypical manifestations in special populations, immunosuppressed either by AIDS or transplant patients? We know that microcephaly was not described before, but, well, we start to see the first deaths with Zika. So this was this publication by Pedro Vasconcelos, showing a fatal disease in adults. You can find the virus pretty much in every tissue that they tested. But this patient was a lupus patient with a strong use of immunosuppressive drugs. So this is the real spectrum of disease or a special population? Well, we also seen some encephalitis associated with Zika. I'm not surprised. Dengue does that. We have some fatal encephalitis with dengue. And could myelitis do Zika? Sure, we also have with dengue. This is from my hospital, this is from my group. So the real spectrum that we are seeing so far is pretty much what we have for dengue. And then we checked, and we just published this a couple of weeks ago, dengue in solid organ transplant, Zika in 2 patients with liver transplant and 2 patients with kidney transplant. The symptoms were much more severe than was described before. All these patients have to be hospitalized. They were immunosuppressed, of course. So this does lead for a more severe disease. We don't know. Now we are starting to see what I really mean Zika infection. And to be honest, I have much more AIDS patients in my hospital than transplant patients. I couldn't find a Zika patient with AIDS, like I never found a Zika patient, a dengue patient with AIDS. So that's something that we have to think a little bit about. So the Zika new presentation. So the large number of new cases will show the complete spectrum of the disease, a spectrum that's very similar to dengue, minus the shock and hemorrhagic fever, or this kind of dengue that we see in Latin America. The dengue with shock and hemorrhagic fever is much more common in Asia than in Latin America. It's not the common presentation in Latin America. We are seeing that, but we have to take care. You die with Zika or you died because of Zika. There's a small difference in this. Any given day, whatever, X people are going to die of heart attack. In the middle of the outbreak of Zika, some of these patients might be with Zika. That can be unrelated. It's just a question of epidemiology. We have to talk a little bit about Guillain-Barré. It's also present in dengue. There is a tendency of see more frequent in Zika, or we are not counting with dengue before. This year I had 4 Guillain-Barré related to flavivirus in my hospital. All of them were dengue, none of them were Zika. But we start to pay attention to this. So microcephaly. This is how we start this whole frenzy about dengue, about Zika. Was first detected in fetus and then aborted fetus. This paper published in New England. This girl was in Brazil. She got pregnant. She went to Croatia, terminated the pregnancy. If it was done in Brazil, everybody was going to the jail. All the authors, because it was a termination done at 32 week, the 32nd week. In Brazil, this is murder by law. Anyway, I don't want to go to exactly, but this paper published by Patrícia Brasil here, okay, I'll run a little bit, was the paper that shows that there is a 30% adverse effect among pregnant women. It was the only paper published with a cohort of patients. So at that time, we set up a cohort in our city also. So my city has 442,000 patients. We are following 1,600 pregnant women. We had 226 suspected women, pregnant women with suspected Zika. 57 were confirmed by PCR. So these one were follow-up. 5 of them in the first trimester, 25 in the second, 24 in the third trimester. So we look for adverse outcomes. So we have adverse outcomes in all 3 trimesters, and we could measure viral RNA in the fetus. So just to use example, 2 fetus that were infected in the first trimester were still viremic at the delivery, about 6-7 months after the infection. So just to summarize this, we have a high rate of clinical outcome, but much less severe. What it means, we do not have any microcephaly in my group. But we do have radiological findings, like lenticular striate arterial vessels, subchoroidal cystus, another small defect that were detected. Some children were born deaf. Some of them have atrophy of the choroidoretinal atrophy, and we could detect the virus in 35% of these children. So the vertical transmission rate may be as high as 50%. That is really high. 2 of these patients were described last month, showing that these subependymal cystus in the brain, here, and this calcification of the vessels of the brain. These 2 children were infected in the 32 week, only 2 or 3 weeks before the delivery. So the preliminary conclusion after 1 year of our cohort, seeing that we have a high risk, it's a high risk for abnormal outcome. That's pretty similar to the paper from Patrícia Brasil, but much more less severe outcome. And the virological confirmed vertical transmission is up to 35%, being 58% in the children with a clinical outcome and 22 without clinical outcome. And we could find clinical findings in all 3 trimesters, different from what was being published before. And my last 2 slides, I would like to talk a little bit about the AD, antibody-dependent enhancement, mediated by dengue, IgG, and Zika infected. This was published by in a very prominent journal, showing that antibodies that react against dengue also react against Zika, but instead of neutralize, they can mediate antibody-dependent enhancement. So the authors say that this immunity to dengue may drive greater Zika replication and have implications for pathogenesis and future programs. This is a very strong consideration. So we start to look at that. And we can tell now that viral load in cytokine profiles does not support this antibody-dependent enhancement in dengue prime Zika infected patients. So we studied dengue and Zika patients, and that work was done in vitro. Now we're talking about real patients, okay? So we got patients with Zika and with dengue, primary and secondary dengue, and patients with Zika, primate or not primate to dengue, and analyze first the viral loads. If you see here the dengue patients, the dengue IgG negative patients or primary dengue, they have this viral load. When you see the dengue positive patients, you see two groups. One group here, that's pretty much the same average here, but this group here shows what we can think as an antibody-dependent enhancement in these patients. These patients had a much higher viral load than the major group. But when we look the Zika patients, there is no difference between the viral loads. There is no difference between clinical symptoms. There is no difference in viral load. And you're going to have to trust me because you can't see. I have to make this figure back. No difference between cytokine levels that are the three markers of antibody-dependent enhancement. Cytokine levels, clinical symptoms, or viral load. So, in the end, what do we know about Zika after 1 year? We know that Zika causes a very mild disease in adults. We knew that before. Zika can cause damage to central nervous system. Well, this is well known in all the flavivirus. Zika is linked to Guillain-Barré. We knew that before, but with much less evidence. Zika causes microcephaly. But what are the cofactors? What do we don't know about 1 year? What's the real spectrum, a burden of the Zika in both adults and children? What's the precise role of Zika in this central nervous system damage? What are the risk factors for Guillain-Barré and the real role of Zika and other flavivirus for Guillain-Barré? What are the risk factors, the epidemiological data, and the precise role of Zika in microcephaly? And what are the other potential vectors for Zika and other routes of transmission, because it still does not add on? And we don't know the basic epidemiological data for Zika. We don't know basic reproductive rates, we don't know attack rates, we don't know number of symptomatic cases, we don't know nothing about epidemiology of Zika. So this is what I want to say. I'd like to thank my students here in red, the one related to this project, my postdocs, and my collaborators in University of São Paulo, Federal de Juiz de Fora, in Yale University, in Fiocruz, at MIT, University of Texas, and Instituto Butantan. Thanks a lot.